Hi everybody, this is Dr. AJ Rastogi from North American Spine and Pain. Thanks for joining us tonight. We're having a Facebook Live question answer session about pain management, about North American Spine and Pain, what we do here, about myself, anything you'd like to know. Please keep the questions coming. Tell you a little bit about North American Spine and Pain. We are a practice that strives to be a comprehensive pain management group. We do conservative care, we do wearables, we do exercise training, medication management within reason when appropriate, injections for minimally invasive approaches to pain control, minimally invasive spine surgical techniques, implantable devices, hardware devices, and so on and so on. We also use a lot of other adjunctive ways to treat the pain. We're big believers in the use of medicinal marijuana, CBD or CBD-THC combinations as a way to reduce opiates or as a way to provide additional care. We have locations throughout New Jersey, Pennsylvania, Delaware. There's about 23 clinicians in the group now, and we can be easily reached at info@naspacmd.com, or you can go to naspacmd.com, which is our website, which will give us our new patient call-in number and the locations for our different offices. Tonight's presentation is really kind of to connect with you guys as a group, to see if there are any questions that you had on your mind, and see what kind of interests are out there. Some of the things that have come up in the past are, what is the difference between different specialists in our realm? What's the difference between a physical therapist and a chiropractor? What's the difference between an interventional spine specialist and an orthopedic or a neurosurgeon? Tends to be more manipulation based. They tend to be more hands-on with their patients, and they use different techniques and treatments to realign a person, to keep them balanced. Physical therapist is more focused on improving your own musculoskeletal system by showing you training exercises, different movements, different strength training techniques, ways to improve your own the balance of your own musculoskeletal system inherently, and get you rehabilitated back to as full strength as you can. A big reason for why we have pain is because we have not done enough things to keep our muscular system balanced or strong. So we sit too long, we stand too long, or we don't do enough activity, or we do way too much in a short time frame. And that starts to cause wear and tear of your core. We'll talk to patients a lot about keeping your core strong, keeping your core well balanced, and trying to change your lifestyle. Looking at your lifestyle, looking at the ergonomics of your office or your home, looking at how your body mechanics are, or what you do on a day-to-day session that might cause more wear and tear, might cause imbalances, or might cause pain. And how do you improve that? So that's part of that conservative treatment goal. Looking at the patient from the whole patient setting holistically. What do you eat? Sometimes we talk about your diet. Sometimes we talk about what are you putting in your body, and how is that going to cause more inflammatory changes within the system that could impact your pain. We do feel that a fair amount of pain is due to inflammation. And if you can keep that inflammation down, you're going to feel a lot better. So that's kind of chiropractic and physical therapy. We also talked, a long time ago when we treated someone's heart and you had to have a surgery, you would have a full open cardiothoracic surgery. And that is a big surgery. It may not be necessary for every occasion, especially if your issue is more mild to moderate as opposed to moderate severe or multi-vessel or complicated. And so over time, technology got better, and we're able to do a lot of cardiac treatment through one of your vessels percutaneously. And so that's a much smaller surgery. It's a lot less trauma. And the same thing has happened to joints, it's happened to GI surgery, it happens to spine. It's happened to what we do in the spine. A lot of the new technologies, a lot of the new approaches that have come out because of the use of X-ray guided techniques. So basically what we're doing is guidance, and we're placing hardware to stabilize or to strengthen a certain segment. So the same technique that we use to fix, say, a fractured bone in the spine, we might place a needle under X-ray into the bone and fill that with cement. That's called a kyphoplasty. We might, for spinal stenosis, we might place a small hardware in the back part of the spine that stops you from fully extending your spine, and that's where the pain comes in when you straighten the spine in spinal stenosis. And a lot of people who are older generally who have spinal stenosis feel better when they get to lean forward, especially like when they use a shopping cart. They really feel better because when you curve your spine forward, when you have spinal stenosis, you're decompressing, you're giving the canal more room, and it feels better. And so that's what those devices mimic, is that improvement that you get when you block the ability to fully extend, keeping that spine as open as possible. There are occasions where maybe you have a ligament, and now under X-ray guidance, we can place a small tool into the canal and remove some of that ligament that's too big or hypertrophic. And if you can remove it without having to do a big open surgery, there are a lot of patients who are going to benefit from that, especially those patients who have more mild to moderate issues, more issues that could be treated through a minimally invasive approach, versus someone who maybe has severe spinal stenosis that's multifactorial. They might be better for a traditional decompressive laminectomy. So I think we're seeing this explosion of new techniques. We're seeing this really plethora of different options now available to different specialists to help treat the patient in a more minimally invasive way. An orthopedic spine surgeon typically is more focused on the bony skeletal system and doing cases that help provide reconstruction of a deformity in the spine. So they might be more apt to being able to do that, but they might have more of a focus on the smaller, the more finesse surgery where they have to tease apart parts of the nervous system. They've also have a lot of experience with the brain, and you have to be very delicate there. So I think that works really well in the spine as well. So I think we've just seen, a really interesting change over the last 10 years in terms of trying to treat pain issues or structural issues that cause pain in different ways outside of either a big open surgery or nothing at all, and then maybe you just grin and bear it, or you take more medications, and that's never a good thing as well. So being able to offer more options to our patients, having more tools in our tool belt is always super important. And then staying on the cutting edge. I think big believers on staying on the cutting edge, always learning. Being a lifelong learner is very important to me. It's very important to all the clinicians in our really seeing what else is out there that can help our patients, especially if they have had a pain condition that we normally didn't have a good option for. To give you an example, we have a very good option for nerve pain in the setting of complex regional pain syndrome. We have nerve pain in the setting of RSD, which is now CRPS, or nerve pain that's phantom limb, nerve pain after a spine surgery where there might be scar tissue wrapping around the nerves. And so I think that's where we've seen a lot of great outcomes with, a regular spinal cord stimulation therapy or device. And there's lots of different companies nowadays to be able to choose from. We've used systems from companies like Abbott, companies like Boston Scientific, Medtronic, Nevro. There are so many different companies, and they all have different applications, different advantages, be it hardware or software for that. And so recently we've seen a lot of great companies come out with devices where we can put a small wire that will stimulate that peripheral nerve, that small nerve, and cut down on the pain, be it in the shoulder or be it in a knee or an ankle, or even other peripheral nerves. We saw some really recently, some really great outcomes with those kind of things. thank you for the warm thanks. We got some patients who actually did undergo spinal cord stimulation therapy with us, and they came on board and they said thank you, so appreciate that. We had a case where someone talked about having a neck surgery and it not going well. And that's the scary part, is when we talk to patients who have tried injections, and we're not a group that, are we missing the pain generator? Are we not putting the medication at the right level or the right way or the right approach? And then if you've really exhausted those non-surgical techniques, or you've got something that just is progressively getting worse, then you're maybe better off seeing a surgeon, getting something permanent, getting something fixed, right? And a lot of our patients are very scared about doing that. There's always a lot of fear and a lot of trepidation behind undergoing a surgery. And so we try to guide them, we try to talk to them about the outcomes, we try to talk to them about the number of surgeries that are done, and then the very low percentages of risks that, or side effects or adverse events that occur with the global number of surgeries that are done. But that being said, there are always people that have had bad outcomes, and I think that scares people away from exploring it. One of the surgeries that has remarkably good outcomes: injections, you've undergone physical therapy, traction, strengthening techniques, change to home, work, lifestyle, all of that, and you're still having that really sharp shooting pain down the arm. There are surgeries to try to fix that, and that's called an anterior cervical discectomy infusion. And so we had one patient who had a bad outcome. She went into respiratory arrest, and those kind of things do happen. They're very rare, but they do happen. And I think when they happen, people are more apt to discuss them. They're more apt to talk about them. When things go well, people don't talk as much about that, right? They go on with their lives. And I think those things can happen if the surgeon isn't very experienced, or they took the wrong approach, or if you do enough of these procedures, you're going to have an issue from time to time. I think in that case, if you had an issue with that, what can you do about it? How can you avoid it? You have an anesthesiologist present during your case. The anesthesiologist should obviously have had an endotracheal tube protecting the airway, managing the airway, looking at that. Maybe there was a bleeding risk that occurred there. Maybe there was some other anatomy that was in the way. It's hard to know the exact details, but that did come up on some of our comments, and we wanted to address that. We had one of the questions was, I have a lot of abdominal pain. I have a lot of pain in the belly, especially in the front. And so we have patients who have had a hernia repair, and if they use mesh, sometimes there's a higher chance of nerve injury or nerve inflammation or scar tissue forming around the small nerves that go into the groin. And a lot of hernia patients have claimed a persistent groin pain, nerve pain in the groin. You could have had multiple pelvic or lower abdominal surgeries that also cause scar tissue. There are a lot of nerves in the actual intestinal system. There are a lot of nerves in your brain, your spinal cord, right? But there are also a lot of nerves in your intestinal system. And so there's a lot of chance for those adhesive scar tissue to form and to cause nerve-related pain disorders within the abdomen, pelvis, the groin. People with pancreatitis also have a lot of chronic. Physical therapists that focus just on really more pelvic pain disorders, where you can help try to train or loosen or improve the way the linings of these, or the arrangement of these different pelvic floor muscle layers are set up. If nothing works, sometimes we'll talk to our patients about using a stimulator again to stimulate the nerves that just go to the abdomen. And there are specific stimulator type systems that allow us to stimulate maybe just the 10th thoracic nerve, which goes out to the belly, right? Or the L1 nerve, which goes just to the groin. Things like that. And so those devices are very helpful, especially in those cases that are very tough to treat, very refractory to other ways of treating them. And when we put that system in, when we put those wires over the nerves that go to those parts of the body, we usually have 4 to 7 days, so they can test it out, so they can see if it works for them. And so it's like a quote like a test drive. It's a way to see if this is going to work for you before you commit to having it implanted. And we've seen a lot of good results with that. We recently had one young lady. She had undergone 8 surgeries for endometriosis. She had a severe amount of pelvic and abdominal pain, and a lot of it was nerve. There's other pain subtypes. You can have inflammatory pain, and you can have myofascial pain, and you can have nerve pain or neuropathic pain. And we treat all of those different pain subtypes differently. When you have primarily a nerve pain related disorder, then we're going to give you medications to help with nerve pain. Typical nerve pain medications include gabapentin, Neurontin. That's a drug that a lot of patients have tried. Usually it's generic, it's well studied, it's a fairly safe drug. Same with Lyrica or pregabalin. That's another example of nerve painkiller. Elavil, nortriptyline, amitriptyline. There's all sorts of different nerve painkillers out there, and they work through different mechanisms. And so trying to figure out what is the best tolerated nerve painkiller for the patient is one of the most important parts of what we're trying to do in the early stages. See if they respond to that. A lot of my GI patients have used medicinal marijuana. A lot of my MS patients have used medicinal marijuana as an adjunct or alternative therapy, and that has helped them considerably. There is something about that combination of CBD and THC that seems to help some of the nerve pain disorders, and it seems to help a lot of those GI-based nerve pain disorders or GI-based disorders that are painful, along with the headache or the migraine that comes along with those disorders or on its own. We also feel like the benefit of medicinal marijuana comes through its benefits on sleep, its benefits on mood. If your sleep doesn't get talked enough about, we focus a lot on it's hitting the cannabinoid receptor in the body and is trying to reduce pain. But I think those additional benefits sometimes outweigh even just the pain relief portion. One of the questions is, I have complex regional pain medicine, complex regional pain syndrome, or CRPS. And medication that I've been using for the past 20 years has been really helping me. And now my doctors are telling me that I need to come down on my pain medications, or I can't use these pain medications. And that's a great question. We get that question a lot. I will tell you that a lot of the patients that come to us from the community sometimes are on an inappropriately high dose of opiate. They haven't had some sort of cancer-related pain disorder, or maybe a spine surgery or a big, large surgery that might have caused ongoing pain issues. Outside of some really great data in North American Spine and Pain that says when a patient comes in, because we have so many tools in our tool belt, we're generally able to reduce their opiate doses somewhere between 30 to 50% over the long term, which is always a good thing. There are some patients who require a higher dose. One of the reasons I think this question in particular is interesting is because when you have a lot of nerve pain, which is primarily what causes or is what is part of CRPS or RSD or complex regional pain syndrome, when you have a lot of nerve pain, narcotics or opiates don't help with nerve pain a lot. There's not a huge benefit, especially if you're on higher and higher and higher doses. There comes a point where that opiate may not be as beneficial unless it has some sort of nerve pain killing effect, which a few opiates do. If you're on really high dose opiates, there might also be people who are on more than too much oxycodone or too much morphine or things like that. What we sometimes ask to do is, well, why don't you come down? Why don't you come down to a lower dose and see if some of that full body sensitivity that might happen with high dose opiates, or some of the changes to immune system, changes to bone density, changes to hormone balances like testosterone, see if those get better. And many times they do. I think the key is to not just bring down the medications, but to offer an alternative non-narcotic option, be it a wearable, be it something that they can do at home from an exercise or meditative standpoint, be it improvements in sleep. be it an injection or an implantable device or a minimally invasive surgery. All of those, or a referral to a consultant who may be able to help them in ways we can't. Because we realize that a lot of our patients who deal with chronic pain also deal with depression and anxiety. And you can treat the pain, you can treat the physical pain, you can treat the organic part of the pain, and that's what we do a pretty good job of. But you still have to treat the mind and the brain. And when we try to get our patients out to someone who can help them with depression or anxiety or PTSD or even maybe addictive issues, it's really difficult to find a place for them to go. They may not get all their insurances. They may not get that patient in quickly enough. And so we brought on a psychiatrist to help us with that and to help us run and manage the mental health within the practice in our communities. And so we've been really excited to have her start and see patients and become part of our integrated network. Back pain causing hip pain in the setting of spinal stenosis. So spinal stenosis, if you look at the canal of the spine and you tighten it around the nervous structures, the nerves that are within the thecal sac, which is after the spinal cord, or the nerves that are exiting, if you compress them, if you make them tighter, generally you're going to have back pain. You might have pain that goes down your legs. You might have pain primarily when you're walking or standing. When you walk, people with spinal stenosis tend to notice that their legs get heavy and weak, and they can't walk very far. And then they have to sit down. When they sit down, it gets a little bit better. So, and the same going back to earlier, when they get to use that shopping cart, they get to bend forward, they get to push the shopping cart and rest on it, and they get to lean forward so they open up the canal. That is something that generally happens in our older population. So, and then instability or changes in the anatomy or alignment of the spine, along with stenosis or tightening of the canal, those can all cause a myriad of different overlaying pain issues. So the spinal stenosis might be causing one thing, and then the arthritis of the spine might be causing another. And so a lot of times when I see patients who have kind of pain along the sides of their spine, like not right down the middle, but along the sides, and it radiates out to the buttock, radiates into the hips, that might be an issue where the arthritis of their spine is causing referred pain into those areas. And what we do there is we'll numb the joints under x-ray 2 minutes after numbing the nerves that go to those joints, the medial branch nerves, or numbing the joints themselves. The patient will usually be able to tell us very quickly, oh, okay, I feel better. A lot of my back pain is improved. Or I don't notice the hip pain as much, and the back pain is. Those things are probably referred pain from the facet joint. You also have a very large joint between your sacrum, which is right before your tailbone, underneath your spine, and one of the large bones of your hip. They come together to make the sacroiliac joint, which is a large joint. And that joint can also get arthritic. And generally that causes more of a buttock type pain, upper buttock area, or in the gluteus, and it will radiate out into the groin or radiate into the hip. If you want to test this out at home, you can basically stand, grab something for balance, and take your leg or the side that hurts, bring that leg up, knee up, and then open the hip up. If you open that hip up or externally rotate the hip, especially if someone were helping you, pulling on the hip, that hurts a lot with people that have SI joint tenderness, SI joint pain, arthritis, and so that's a common finding. A lot of times they will notice almost immediate relief with a therapeutic or a way to treat the person. We'll put a little steroid in the joint to reduce inflammation, and it's also diagnostic. When we numb that joint and we get them off the table and they tell us, oh yeah, that feels a lot better, that's a really good sign. That's an SI joint pain that we have been able to diagnose. And because all of these structures, the facet joints, small joints of the spine, the disc, the spinal stenosis, the SI joint, they're all very close to each other. So a lot of their pain presentations can overlap, and a lot of times they're presenting in the patient synonymously, so they can cause a lot of these different pain pictures to overlap and to look more vague and not textbook, not classic. Classic textbook presentations of pain don't happen a lot because they usually don't happen in isolation. Let's see, one of the questions, I had a radio frequency ablation in my back and conduct tip, and we laid on the nerves that go to those achy joints, those arthritic joints in the low back. We use heat and electricity to try to turn those nerves off. Now that will turn off those peripheral nerves from months to years. It depends on how quickly you regrow these peripheral nerves. They do grow back, unlike the brain, spinal cord, central nervous system doesn't grow back. Peripheral nervous system does. So maybe you got a lumbar radiofrequency ablation and you didn't get a whole lot of relief. Why didn't you get a whole lot of relief? Maybe because, again, arthritis doesn't usually happen in isolation. You may have other issues that are still there. So we have cases, and it's not super common, but there are cases where a patient has gotten maybe an epidural steroid injection to reduce inflammation in the canal. Then that didn't work. They still have back pain. So we're thinking maybe it's arthritic. So we do some test injections. They respond. They do the ablation. They get. We've treated two of the most common reasons to have chronic low back pain. So sometimes we'll look and see, is it a peripheral nerve issue? We had a great case with someone who had a cluneal neuralgia. The cluneal nerve runs along the top of the iliac bone, and it can cause kind of this area of pain just above that bone and in the back off to the side. So sometimes it's that, sometimes it's a peripheral nerve issue, or sometimes it could be something wrong inherently within the disc. So we call these intradiscal pain issues, or discogenic disease. What that basically means is the disc, there might be tears within the disc. There are nerves on the outside of the disc, or the ring of the disc, which is a tough rubber band material called the annulus. And that nerve can get irritated by changes within the disc. Those tears within the annulus can cause pain. End plate of the bone and the top level or the bottom level of the disc, that could also become very painful. And there are ways to treat that. There are ways to turn the nerve that's being irritated by that issue off. There's some new technology and new modalities coming out where we're seeing a few pairs covering a treatment where we inject certain types of biologic products into the disc to improve the health of the disc, to hopefully promote better, healthier, stronger tissue there. Many times if someone has a fair amount of pain at a level and that level is stabilized, that also is a way to take pain off of discogenic disease. We see it a lot in young military personnel, paratroopers. They would jump out and they would land real hard down on their boots, and that would cause a shock wave throughout their disc system. And so it'd be a young person who shouldn't have these types of problems, but because of their activity, they had damaged their disc and they were coming in with a lot of discogenic pain. There were usually pain with sitting, pain with bending forward, pain with lifting, bending, things like that. And sometimes that disc isn't pushed out enough. It's torn inside, but it's not pushing out into the canal, irritating a nerve root. So it's not causing that traditional leg pain that we're looking for. It's just causing more of this sharp stabbing, very, very bothersome back pain that is sometimes similar and sometimes very different from the back pain that we would expect in the setting of spinal stenosis or the back pain we would expect in the setting of arthritis. So one of the questions is, in the setting of post-spine surgery and spine fusion, can you talk a little bit about why, if I'm not feeling better, why don't they just take it out? Why don't they take out that hardware? And I think, you know, the vast consensus on this is that if you're going to remove hardware, then you're removing a support structure. You had to open up the canal, you had to decompress the spine, so you had to remove some weight-bearing or some load-bearing bone or ligaments. And the fusion hardware was put in place to give you structure and stability. Or it was done to protect a level where you might have lost some height in some of the tissue, or it's slipping, it's weak. There's a listhetic segment that's mobile, that's unstable, and now you need to fuse it to provide structure and stability. And so if you're going to remove that because you think maybe that's going to make you feel better, the risk is that it won't make you feel better. You've undergone another surgery, which is going to cause more scar tissue or more pain or more trauma, and your body doesn't like multiple surgeries in the same spot. It's generally not a good sign. It's generally not associated with good outcomes. So we try to avoid it. We try to find other ways to try to control the pain. And if you're going to remove the hardware and it causes an instability or it removes the stability of that structure, and if you don't have that, then that's not a good way to go. So I think that's usually the reasons why a lot of people that still have pain after surgery. Why do you have pain after surgery? So say, for example, you got a fusion and you fused the part of the spine. Let me see if I can grab this model here. So if you look at this spine model, and if you fused this level and this level, and now those levels are protected, and the pressure, the action that would have been imparted on this level, it's got to go somewhere. So it will usually go above and below that fused level. So that's why people with a fusion are more at risk for what we call adjacent level disease. It's basically an issue where they have more pressure and more pain and more debilitating issues that occur maybe at the facet joint surgery. Maybe the surgery worked and it lasts a long time, but now the spine is changing. They're getting older, something happened to them, and now you have a disc herniation above or below the fusion, and you should get a MRI with and without contrast to identify the anatomy that is affecting the patient at their pain levels. Or maybe they have arthritis above or below their fusion, and that needs to be treated. And the way to treat that is by putting numbing medicine on those joints, again, right under x-ray, seeing if they respond right away, seeing if some of their pain goes down or a vast majority of their pain goes down. So that's probably the best way to tease that apart and to tackle it. The times that we really strongly push for removal of spine hardware is if obviously that hardware isn't fused well to bone, it has cracked, it has moved, it has come out, misaligned itself, things like that, where it's really, really one of the questions that comes up a lot is, I have pain in the back, and I'm a little older, I have osteoporosis, I have some lighter, weaker bone structures, and I had a compression fracture. And is that compression fracture causing my pain? And we won't know until we examine you. And what we do is we really push on the level in the back, on that spinous process, the little knobs in your back that you can feel on your back. And we see if that causes you pain or discomfort. And the thing that I think a lot of people don't realize is, unlike if you break your arm, you can cast it, and unless it's a really complicated fracture, it's going to heal, and it's going to heal okay. Or you can do a surgery to realign it and fuse it and give it proper fusion. But in the back, it's really hard to stabilize the day as we go about our day, and it may, in some people, a lot of people get better, but in some people, the way the fracture heals, it never solidifies in such a way that everything's compacted nicely and there's no more pain. So one of the theories is that there's still poorly formed fusion sites or union sites of the bone, and when they move, there's reproduction of pain. And so in those patients, we will do a procedure called a kyphoplasty. Kyphoplasty is where we take a needle and under x-ray we place it into the bone, the fracture site or the level that's fractured, and we will open up a balloon, and a balloon will compact the bone so it creates a nice uniform bubble or circle, and then we will fill that with cement. We'll try to fill that as much as possible, and there's lots of different tools and companies and devices out there that are used to try to create a better, stronger, more stabilized vertebral body. And we've got some great videos on our website or on our YouTube channel or LinkedIn that you can look at of patients that have undergone those types of procedures, and a lot of the other ones that I talked about from a lot of the great docs at North American Spine and Pain. So if you want to know more, if you just want to see a patient testimonial, if you want to talk to maybe some of our patients that have had this done, we've got some really nice people who've been willing to volunteer time, who they themselves were very scared to get something done. They did very well, and now they want to help other people understand the procedure and ask questions directly to someone who went through it. Maybe that sometimes people need more of that than they do just talking to a physician or the surgeon or the interventionalist who's going to do the procedure. Somebody was asking about the mild, and what that stands for is mild, minimally invasive lumbar decompression, MILD. And so when you have someone who has stenosis, called the spine to open it up, and that's called a decompressive laminectomy. So you take the spine, it's a circle, it's really tight, you open up the back wall, and now the spine has a lot of room, right? That's a big surgery. It can be traumatic in some people, and not everybody does great from that. So, a lot of the research and development that's happening is looking at minimally invasive ways to remove just the offending tissue structure that's causing the problem. In the case of spinal stenosis, the back wall of the canal, there's a ligament called the ligamentum flavum that can become hypertrophic, that can become too big, too thick, and it can start to encroach on the canal, making it tighter. So if we can go in through the natural openings of the spine, the natural bony openings under x-ray, enter the spine, remove just the ligament without having to remove the back wall, population that tends to be older. So if we can do something smaller, more minimally invasive, less time in the OR, less bleeding, less risk or damage or scar tissue formation or damage to nerve structures, they're going to do better for that. They're going to generally respond better. And say you're not able to take enough out, or say the stenosis is too overwhelming that small tool isn't enough, that patient can still undergo the bigger, more involved procedure if they need it, but maybe you've avoided a lot of trauma in someone who may be too sick or too frail to undergo it or wouldn't be a good candidate at that time. Maybe they have moderate amount of stenosis and they don't need as big a surgical procedure. So I think that's where we've seen really good outcomes with the mild procedure, minimally invasive lumbar decompression. We've also seen a lot of good outcomes for opening up the canal by putting in the spacer, back wall of the spine. So one of the questions we had was, what do you do for discs that are herniated when injections don't work? So that's a great question. So you have a disc herniation, it's pushing on the nerve that goes down your leg, and you probably notice that when you bend forward, when you're sitting and you straighten your legs, or when you are driving or sitting at the computer, you start to notice more leg pain. It's because sitting increases pressure on the disc, a lot more than standing does, by about 40%. So when you stand, you get to use larger muscles in your gluteus and your legs, and they support you better, they take some weight off the back. But when you sit, you don't get that benefit. So if you sit for more than 30, 45 minutes, your muscles that are supporting your spine, they get fatigued. We're not meant to stay in one place too long. So we really encourage you. I've seen these articles. Sitting is the new smoking. And in many ways, it's true because we sit a lot more than we used to nowadays. And when you don't get up, when you don't get the blood that's pooled in your legs out, when you don't move around, you start to build up changes in your body from a metabolic standpoint, which can lead to weight gain, which can lead to osteoporosis, which can lead to joint stiffness, and can lead to even things like diabetes. So, or blood clots, right? Dangerous things like that. So you got to move around. No matter how bad you're feeling, if you can move around a little bit, it's better than not moving around at all. And so when we sit too long, we're putting pressure on those discs. We're sitting a lot more than we used to. And now those discs are taking the brunt of it after 30, 45 minutes of sitting in one place. The muscles are weak. The muscles are tired. So what you can do if you have to sit is wear something as a protective garment to take some strain off the back, to give those muscles a break. Take a walk, 5 minutes, do some stretching, move your legs, get some blood pumping, do some calf raises. All of those things are super helpful. And that is going to hopefully lessen strain on the disc. So the more we sit, the more our muscles get tired, the more we put pressure on our discs, the more our discs herniate. And now they're encroaching, they're putting pressure on the nerves that go down our legs or go to our arms, right? And so if you've done physical therapy, if you've used medication management, if you've done rest, you've done all of those things, not getting better, or if the pain is so severe and intractable that you're going to go to the ER, or you can't do the things you need to do in life or at physical therapy, then usually we'll recommend an epidural steroid injection. And an epidural steroid injection is placing a small needle under X-ray into the openings of the spine, the bony openings, where your nerve is, and using a little dye to see where the medication is going to go, seeing what we can see of the nerve and the sheath that the nerve lives. Now, if we do that, then 75% of the time patients do better. A lot of their pain goes down because a lot of pain in the setting of a disc herniation is inflammatory. So if you can make the inflammation go away, a lot of people do pretty well. Then they can go back to physical therapy, they can do the exercises they need to, they can make the changes so that hopefully that pain doesn't come back. But if we've done that, we've done a couple of injections, you're not getting better, then the next step is looking at that MRI and saying, okay, is this more of not an inflammatory issue on its own? Is it also a structural issue? Is there, this disc is so big that it's compressing the nerve? Do we need to get that disc off the nerve? So sometimes we'll do a test injection called a discography. Discography helps us identify by putting a needle in the disc or more than one, injecting it with dye under live X-ray and seeing what that pattern inside the disc looks like, seeing if the tears within the disc, seeing if the disc, when you put pressure by adding the dye, you're going to put pressure in the disc, does that reproduce the type of pain that they normally have? Can we use that to go in and do maybe a microdiscectomy or maybe a more invasive procedure, try to get that disc off the nerve? And there are lots of different surgeries out there. There are very small surgeries like endoscopic discectomy, and then there are medium-sized or small surgeries like traditional microdiscectomy. There have been percutaneous disc decompressions. There's lots of different ways to get the disc off the nerve. So, there's just been a real explosion in advancements, and so one of the things we really want to try to do is do more of these Facebook Live events to build awareness of all the new options that are available. They don't have to live in pain, be it physical pain, be it mental pain, be it a combination of both, more likely than not. And how to reduce or how to not see just maybe medications or just injections or just surgery as the only choice. Really trying to look at each person from a global sense, a bird's eye view, and say, okay, what is the best for that person so they can be the best person they want to be and have a really functional, really high quality of life. And that's what, at the end of the day, we're trying to provide. So we're going to do a ton more of these. We really appreciate you joining us tonight. I had a lot of fun. And from the questions, we got a lot of great questions, got a lot of engagement. So thank you, everybody. We hope you have a great night. And we look forward to seeing you soon. Take care.